In this lecture, I will speak about obstructive jaundice. The objectives of this lecture that the student should know differential diagnosis of obstructive jaundice, the proper approach and workup for a jaundice patient, basic treatment for the most common causes of obstructive jaundice. Let me speak few words about normal physiology of bilirubin. In spleen, as you could see in this diagram, hemoglobin degraded to heme and globin. Heme then converted to the bilirubin, which is unconjugated and protein bound. Then in liver, unconjugated bilirubin transported with ligand or Z protein, then conjugated with glucuronic acid, become conjugated bilirubin, and it is water soluble. Then from liver transmitted to the intestine. In intestine, conjugated bilirubin converted by bacterial process to urobilinogen. Then 90% of this urobilinogen converted to oxidized urobilinogen, which is called stercobilirinogen, and the rest 10% of urobilinogen returned back by portal vein to the liver, as you could see in this diagram, and then from liver to the kidney, and urobilinogen excreted in the urine. What is jaundice? It is yellowish discoloration of skin, sclera, and mucous membrane that result from excessive deposition of bilirubin in tissues. Jaundice develop when serum bilirubin levels more than 2 mg per deciliter, i.e. 34.2 micromole per liter. Typically can be detected if serum bilirubin level above 3 mg per deciliter, i.e. 51.3 micromole per liter. Jaundice can be categorized as prehepatic, hepatic, and post-hepatic. Broad differential diagnosis of jaundice, I would give a focus for only the last column, which is biliary obstruction, obstructed jaundice. This is the focus of this lecture in surgery, obstructive jaundice. The first three columns related to the jaundice in medicine. I give a focus for only the last column of obstructive jaundice, in which the bilirubin conjugated bilirubin increase, in which the main underlying cause is stone in common hepatic or common bile duct, or stricture in common hepatic, common bile duct, or cancer in around common bile duct or in common bile duct, or chronic pancreatitis or primary sclerosing cholangitis. And you could have a look at as well to the different other causes of jaundice unrelated to obstructive jaundice if you want. Now, obstructive jaundice, the subject of our lecture. Biliary obstruction, the causes. Biliary obstruction, obstructions of common bile duct or common hepatic duct, divided into three groups: intraluminal, intramural, extraluminal. Either inside the lumen of common hepatic or common bile duct, the pathology inside them, or the pathology in the wall of common hepatic or common bile duct, or the pathology outside the wall of common bile duct or common hepatic duct. Now, intraluminal causes such as stone in common hepatic duct, common bile duct. Two, I'm only reading the intraluminal causes. Number one, stone in common hepatic duct or common bile duct. Two, daughter cyst intrabiliary rupture of liver hydatid. Group 2, intramural causes. 1, cholangiocarcinoma. 2, stricture. 3, biliary atresia in neonate. 4, choledochal cyst. 5, primary sclerosing cholangitis. Group 3, extraluminal. Example: 1, carcinoma of head of pancreas. 2, chronic pancreatitis. 3, liver cancer or metastatic cancer. 4, periampullary tumor or cancer, which is duodenal tumor. 5. Occasionally acute cholecystitis, gallstone complication, and 6. CA gallbladder. Approach and workup management of obstructive jaundice. Patient present with skin discoloration suggestive of jaundice. Firstly, you need to take history, examination, and investigation, and I will speak in details about each point of them. What is the aim? The aim of this approach is to know when direct or indirect hyperbilirubinemia. 2. If it is direct, then what are the possible causes of obstructive jaundice? This is the aim of our workup or approach. So in the next slide, I will speak about in detail history, examination, and investigation. History. We need to take the duration of jaundice, to onset and progression and depth of jaundice. 3. Itching. You know it is characteristic for obstructive jaundice that patients get itching and itching mark. Change in color of urine and the stool. You know in obstructive jaundice the urine become tea color urine and the stool clay color or pale. And again the patient could have mostly have a pain, fever, and fever in case of acute cholangitis, stone obstructing the CBD, and the patient developed acute separative cholangitis, then the fever are going to be a high grade fever. So pain, jaundice, and fever, Charcot tried. I'm only repeating just to make the story linked or connected to each other. Number 5, further GI symptoms, for example nausea and vomiting, hematemesis melena. You know patient with hematemesis and melena and he presented with jaundice, that means could cause with liver cirrhosis, portal hypertension, esophageal varices, and bleeding. Again, abdominal distension is important in history, so this is caused with ascites, and that's the underlying pathology could be pregnancy or liver cirrhosis. Number 7, other systemic symptoms, for example oliguria. We need to ask about it to exclude hepatorenal shutdown, changing consciousness to see it, or in order to exclude hepatic encephalopathy, bruises to exclude any coagulation disorder due to deficiency of vitamin K in case of obstructive jaundice. 8, history of hemolytic disease such as sickle cell anemia, thalassemia. 9, history of blood transfusion. 10, history of previous similar attack. 11, previous surgery like liver surgery, for example for hydatid, and then the patient got jaundice, or biliary surgery, for example laparoscopic cholecystectomy. 12, any chronic liver disease or chronic bowel disease, for example patient got ulcerative colitis, then he might got primary sclerosing cholangitis and jaundice. 13, family history of jaundice. 14, alcohol. 15, further social history, for example uncovered sexual life or contact with affected patient like doctors, and multiple recent travels, history of multiple recent travels to get, for example hepatitis. Now number 16, drug history like rifampicins, and we've got lots of drugs leading to or causing jaundice. In this slide, I will speak about examination of patient with jaundice. First of all, general examination. This is to confirm the presence of jaundice by examination of eye and mucous membrane. We need to look to the depth of jaundice. We need to check whether the patient pale or not, and to check his or her hydration status, and to look and see whether there is a bruise or not, and checking vital sign including the temperature, pulse rate, blood pressure, and so on. 2, signs of chronic liver disease. Check for signs of chronic liver disease: xanthelasma, spider nevi, gynecomastia, tubutrine contracture, clubbing of fingers. Actually, these examination for general jaundice, not only the obstructive jaundice. 3, ordinary abdominal examination, for example dilated veins, abdominal distension due to ascites, and then the examination of ascites, as you know, shifting dullness and transmitted thrill. Examination of liver, size, shape, surface, enlargement of gallbladder, and what we called it Corvozier law, positive or negative in case of CA head, pancreas, the corvus yellow become positive. It means there is palpable gallbladder in case of jaundice due to CBD stone. Then the corvus yellow become negative because there is no distensions of gallbladder and impalpable gallbladder. And then check for spleen, presence of spleen or not, splenomegaly I mean, and any abdominal mass and so on. Investigations of patient with jaundice. First of all, liver function test, which is very important blood test in case of jaundice. The changes that will occur in liver function test in obstructive jaundice as follows. Total serum bilirubin will increase. Conjugated or direct bilirubin will increase as well, while unconjugated indirect bilirubin will be normal. And alkaline phosphatase will be increased, while ALT and AST would be normal or increased. In stool and urine examination of patient with obstructive jaundice, urobilinogen will decrease in urine, and the urine color become tea color or dark because it contains conjugated bilirubin. In addition, stool would be pale, clay color because of absence of stercobilinogen. Then ultrasound scan will show dilated common bile duct, which is common finding in case of obstructive jaundice, and plus possibly presence of gallstones if the underlying cause of obstructive jaundice is stone, plus presence of hydatid cyst, for example, possibly in the liver if the cause of obstructive jaundice is intrahepatic biliary rupture, I mean daughter cyst passed downward in CBD. In addition, in obstructive jaundice, in ultrasound, we will see no splenomegaly. It is not medical disease related to the jaundice. And then after ultrasound, we will send patient to the MRCP. MRCP here is very important and diagnostic and confirmative. We will see dilated CBD and dilated common hepatic duct, plus understanding or knowing the possible cause of obstruction, for example stone, which is common finding in case of obstructive jaundice. And sometimes we might need to send patient with obstructive jaundice to CT scan of abdomen, contrast abdominal CT scan, sometimes requested if the underlying cause, for example hydatid cyst of the liver, and patient presented with jaundice, or mass or tumor of the liver, or pancreas, or periampullary tumor. So this is important to know all these investigations. So let us put all these information, history, examination and investigation in this algorithm. Now patient presented with skin discoloration suggestive of jaundice. Next step, we will take history, examination, investigation, and we've already done that. We've spoken about history, we've spoken about examination, we've spoken and mentioned the investigation. Now the algorithm, either we will go to side of indirect hyperbilirubinemia, and this is outside of the scope of this lecture. Patient will go to the medicine, or the patient, after history, examination and investigation, we discovered that the patient got direct hyperbilirubinemia. Then the differential diagnosis at that time, either hepatic, which is medical disease, non-obstructive, or post-hepatic, which is surgical, I mean obstructive jaundice. If it is hepatic jaundice, then the answer will be, the next step would be liver biopsy and send patient to the medicine, again outside of the scope of this lecture. If it is post-hepatic, I mean obstructive jaundice, so we will continue to speak about this because this is the subject of this lecture. In this slide, I will speak about treatment of obstructive jaundice, and this is consist of two parts. Part 1, supportive treatment, which include admission of patient to the hospital, plus fluid and electrolyte balance, giving careful IV fluid, and corrections of coagulation defects by giving vitamin K. We usually use 10 milligram vitamin K intramuscularly. Prevention of infection by using antibiotics. We usually use third generation cephalosporin plus metronidazole. And finally, preventions of hepatorenal syndrome and hepatic encephalopathy by careful using of IV fluid and diuretics. This slide, I will speak about the second part of treatment of obstructive jaundice, which is interventional or surgical treatment, and this will depend upon the clinical scenario of the patient. If the underlying pathology is choledocholithiasis, I mean bile duct in the stone, then the treatment would be ERCP, endoscopic retrograde cholangiopancreatography. If this technique fails, then go to the surgery, and the surgery include either A, supraduodenal choledochotomy and the stone removal, and this is called CBD exploration, or B, transduodenal centrotomy and the stone extraction. Definitely we need to treat cholangitis as mentioned above. Or the scenario is tumors, and the underlying cause of obstructive jaundice is tumor such as CA head pancreas or periampullary tumor. If it is resectable, then the treatment is a curable resection such as Whipple operation, or if it is irresectable, then the treatment is palliative surgery such as triple bypass surgery. That is, we will usually do it in case of irresectable CA head pancreas. If the tumor appear inoperable from the start and even palliative surgery cannot be achieved or is not indicated, then the drainage by endoscopic stenting, then the treatment is drainage by endoscopic stenting by using ERCP. I mean, put a stent inside common bile duct by using ERCP. If it is failed, then by PTC, percutaneous transhepatic cholangiography, as in some cases of cholangiocarcinoma, in order to drain the bile and decrease jaundice. And then shift to number 2, which is chemoradiation, and definitely for very advanced cases we need to continue in supportive care. This slide shows ERCP and showing presence of stone in the main bile duct. Picture for ERCP and showing a stone inside the main bile duct. And this is a PTC picture showing a stent inside one of the dilated biliary tree, and this is ultrasound showing dilated common bile duct. Thank you very much and good luck.